health inequities as those differences in health between groups that are unfair and unjust. Health equity is about pursuing the elimination of these health inequities. And so just to be clear, when we speak about health equity for the remainder of this webinar, that is what we are describing. And we certainly recognize that many of the current public health staff working on social determinants of health are in fact also pursuing health equity. If I could have the next slide, please. Soon after the amalgamation of our work group, we created a work plan and identified 4 major objectives for ourselves. So you'll see here that the first objective is to promote more social determinant of health work in Ontario public health units. Our second objective is to advocate for policies that reduce inequalities in health. The third is to support knowledge exchange that's related to health equity. And the fourth is to facilitate the sharing of tools and resources. If I could have the next slide, please. So when we break down that first objective of promoting more social determinant of health work, you'll see here that we identified several activities. We are addressing all 5 of these. So working on foundational standard, identifying ways to strengthen the mandate in the Ontario Public Health Standards, identifying health equity resources for access by local public health practitioners, strengthening the work on priority populations, and then finally the last link, which relates to the health equity indicator work, is to work with partners to identify indicators that we could use to measure, monitor, and hopefully evaluate this work as we move forward. Next slide, please. I'm not assuming that everyone on the webinar is familiar with the Ontario Public Health Standards and the content, but suffice it to say that the determinants of health are defined in the introduction to Ontario's Public Health Standards. And if you aren't familiar with the Ontario Public Health Standards, they are available on the web, so you can read them. And there you will find that besides the introduction, the foundational standard describes social determinants of health in the principal needs and impacts. In fact, they are recognized as being fundamental to our work. They are recognized as being a key component, and the Ontario Public Health Standards do incorporate and require boards of health to address these determinants of health throughout, often by using language such as priority populations. And in addition to the Ontario Public Health Standards that govern our programs, we have organizational standards, and one in particular, Standard 3.2, does require boards of health to have strategic plans, and within those plans to describe how equity issues will be addressed in the delivery and outcomes of programs. So social determinants of health permeate the Ontario Public Health Standards. Next slide, please. So why should we measure health equity? Certainly the health equity indicators were first conceived as potential performance indicators, and in fact early in our history we did submit them to the Performance Management Working Group for consideration. And since then we have had consultations with both the Performance Management Working Group, which is a committee or of the Public Health Division, and with Public Health Ontario. And in those discussions, I think what evolved was a recognition that we're not there yet We aren't ready to use these indicators to measure performance, but rather these can be tools for shared learning. And in fact, hopefully they can assist all of us who are working for boards of health to acquire a baseline and to focus, uncover, identify, perhaps prioritize those areas where we need to acquire more skills and expertise. Next slide, please. So the health indicators, why measure? This list suggests different rationales for collecting population health indicators, and the reasons are very similar for why we would want to measure what local boards of health are doing to reduce health inequities. Our health equity indicators, we believe, really focus on the first two bullets on this slide, which are for the education, our own education, as well as the education of the wider public to be able to, we could use them to report on the activities, on our work, as well as for research to help us evaluate how effective we are with our strategies on addressing health inequities. Next slide, please. So we will now present, we're going to walk you very, very slowly and carefully through the 6 health equity indicators that we have developed. We're hoping that after each one, you can have, there will be enough opportunity for you to ask questions of clarification, so that when you do go to the survey that we have sent out for consultation to collect your feedback, you'll be clear and you'll be able to give us feedback that will be useful for us as we move along to finalizing these indicators. If I could have the next slide, please. With each indicator, the electronic survey asks 3 questions, and they are the same 3 questions. So the first question is, what do you perceive your health unit's capacity is to actually collect this information? And we ask you to indicate whether it's a low or a high capacity. The next question refers to the usefulness of the indicators, how useful they are for planning, for implementation, for assessment of health unit or board of health level initiatives to reduce health inequities. And again, we're hoping that you can comment on all 3, planning, implementation, and assessment. And then finally, the third question is really an opportunity for you to suggest changes to the indicator or requests for additional accompanying information that might be helpful. You'll note that the indicator document does actually have definitions, limitations, notes, data sources, and appendices, but potentially we recognize certainly that there is room for more if needed. So we hope that you will be able to indicate that in your responses to the consultation. In addition, we've added a part 2, and the part 2 is on request from Public Health Ontario. Public Health Ontario is now busy planning its activities for the next year to support boards of health and staff, and so they've asked if we could also assist them in doing a bit of a needs assessment. So there are 2 sections in part 2. The first section is there to ask for input for needs and priorities, and these are relative to the foundational standard. And the second section are questions that will help Public Health Ontario target their capacity building efforts. The information collected in part 2 will go directly to Public Health Ontario, and their staff will be very grateful for anything that you can provide. So please do also ensure that you reply to part 2 on the electronic survey. So I'm going to hand this over now to Dr. Lamptey, and she will walk you through the first indicators. Nikoshi?
Thank you very much for handing that over, Dr. Pellizzari. I'm speaking on behalf of Cam McDermott for these next couple of indicators. Indicator 1 references the Ontario Public Health Standards Foundational Standard Population Health Assessment and Surveillance Protocols requirement to issue and report on health status in the jurisdictions of boards of health. And this indicator asks what percentage of these reports on health status disaggregate data by social determinants of health where possible. With this particular question, we're interested in reports where social determinants of health are explicitly linked to health status measures rather than just demographic reports where there is no explicit link to health status. If we move on to the next slide, please, you'll see that although the intent of this indicator is helpful, there are some limitations potentially in the way that health units may be able to report that. And part of that has to do with the fact that health units vary in terms of their size. So the ability to produce robust estimates of health status broken down by determinants of health may differ. Furthermore, some data like hospitalizations are not explicitly linked to the social determinants of health, which means that we might also require some geographical analysis. And that geographical analysis may also be beyond the resources of some health units. How health units generate their health status reports may affect this measure. For example, a health unit might do a single health status report, or they may do 10. Not all health status measures may be amenable to social determinants of health analysis, so a single report may not have all portions analyzed by the determinants of health. Some health units might choose to focus on health status measures that are priority or have been demonstrated to be closely linked to determinants of health in their context. So in summary, these measures prompt really a chance for reflection rather than simple comparisons across health units, because as we know, not all health units are created equally, and there may be constraints in size, resources, and institutional practices in reporting. If I can move on to the next slide, please, and then the slide after that. The second indicator has to do with what percentage of Board of Health reports on health status include an analysis of the social determinants of health for a specified time period. If we move on to the next slide, the reason we included the time component is that different data sources might be refreshed at different rates. For example, for the most part, income information is only refreshed with each cycle of the census. And so this, in turn, influences how often reports are done. As core social determinant of health information becomes older, there might be less willingness to include it in a report. Smaller health units might also combine multiple years of data to provide a single robust estimate in a report. So this means that time series reporting might be even less often than single-year data when it's available. But in general, the spirit of this requirement is that data should be considered with historical comparisons when possible, and this indicator, therefore, might be reviewed less often than indicator 1. If I can move on to the next slide.
And we do have a question, Nakushi. There's a question from Virginia McFarland. Which determinants of health would qualify, and what is the minimum number? We already look at health status by geography and sex. Would that be counted?
That is a good question. I think in terms of which determinants would qualify, I don't think the work group specified that as of yet, and we're looking to feedback on that through the survey. Cam, who generated this indicator, probably could provide a more detailed answer, but I do know from his notes here that he's really trying to get at determinants that are explicitly linked to health outcomes. And in terms of sex, that might not always be a social determinant. In some frameworks, it's a biological determinant.
Thank you. I don't see any more written questions, so I'm going to ask our next presenter to pick up and lead us through the third indicator. Dr. Tran?
Right. So the third indicator fits nicely into what Nicosia was mentioning about priority populations. There's 5 components to it. It's about not only identifying the priority populations, which is really bullets 1 to 3, but also whether or not after identifying the priority populations, there's plans and adjustments made to the programs to meet their needs, as well as monitoring or evaluation. Next slide. So this slide is more about the process of how explicit or how global they're identified. So there can be a standard or standardized or explicit process in terms of embedded in the operational planning policy and procedures that determine that, for every time you're developing a program or plan, you actually have to identify a priority population. The next point is about whether or not there's a specific template for it. So for some programs, like there's a potential on the operational plan template, there's actually a column for priority populations. Next slide. This slide is more about who really determines priority populations, or what type of either direction or flexibility a health unit has in terms of what the priority populations for either specific programs or not. So in the very directive case, the first case, the health unit has a pre-listed selected priority populations, whether it's people low income, they're francophone or something like that, that applies to all programs and services, that all of them have to use these as priority populations. The second is more suggestive. The health unit has a list of possible priority populations, similar to what the Health Equity Impact Assessment of the Ministry has, where they list 10 different groups: SES, education, housing, and then people have to choose from it. So it's very directive. It's suggestive. And then the third is very open to interpretation, to how health unit staff want to interpret priority populations without any specific suggestions or directions. Next slide. This is about the actual definition of priority populations, and the reason why is because under the Ontario Public Health Standards, it's very broad and open to interpretation. It mentions that priority populations are identified by surveillance, epidemiological, or research studies, and are those populations that are at risk and for whom public health interventions may be reasonably considered to have substantial impact at the population level. So one of the issues with this is that it doesn't necessarily distinguish between those that are differences in health outcomes that are socially produced, whether it's income, housing, or education, or those just have an increased rate of diseases or health outcomes regardless. So it could be actually genetics, it could be gender, because the OPHS doesn't necessarily distinguish between target populations or populations of interest and priority populations. So this is more to specify how a health unit interprets the broader definition. Next slide. So this is about how once they're identified or not, I guess, whether they're incorporated into the programs and services. So the option is they're identified, but there isn't actually mechanisms to necessarily, they're just there as an identification, but there's no process in place for modification of the program services to help meet the needs. There are then, as you further go down, they're identified, and actually programs and services are modified and there's specific actions. And then we also want to get a sense of how much changes programs do to meet and tailor the needs of specific populations. Next slide. And the last slide is really closing the loop in terms of whether not only is there planning and identification, whether priority populations are and their health outcomes or needs are monitored or evaluated in terms of looking at actual reduced health inequities or levels of services across priority populations. And then the idea is to give us some examples. So it's also a learning exercise in sharing across the health units. And that's the last slide before questions.
Okay, so I see some people are having some connecting issues, so hopefully that's being taken care of, but I'm not seeing any written questions pertaining to priority populations in the chat line. So I think we'll move on, and perhaps at the end there'll be an opportunity. So back over to you, Dr. Lanty.
Thank you, Rosanna. So if I can have the next slide, please. The next set of indicators have to do with assessing whether boards of health have mechanisms to ensure that operational plans include a health equity assessment of programs and services. And this has some related questions to kind of gauge the depth of the structures available to support that. We ask whether equity assessment of programs and services is encouraged or required, and also whether the Board of Health provides a standardized health equity assessment tool for staff to assess programs and services. And we're also, because the spirit of this is sharing and learning, we're also asking respondents to list or attach any tools that they use in their practice. If I can have the next slide, please. The reason we ask this question is that we understand that boards of health have potentially many layers of operational plans that describe the activities of teams within a service area or within a program division or a broad activity area. And we're trying to gauge whether staff preparing those plans are expected to systematically consider health equity when planning and evaluating the programs and services. For example, a mechanism could be a prompt within the actual operational plan to outline equity-focused activity or specify use of a standard equity tool in the planning process. And again, this is related to a requirement in the Ontario Public Health Standards that boards of health should tailor their programs and services to meet local population health needs. You can see that potentially from this question we can learn how widespread the use of these mechanisms could be across health units, to what extent this is enabled by the structures at the health unit, and also get examples of the variety of tools potentially in use. If I can have the next slide, please. So we've just provided an example of the kinds of things we would be trying to learn about from this question. For example, a health unit could have a tool that planners use when they look at the impacts of their programs and activities on health equity. If I could have the next slide, please. So why is this important? Well, I did mention the Ontario Public Health Standards requirement, but also when I first joined this health equity work group a couple of years ago, we issued a survey to identify the range of activities health units were doing on social determinants of health. And the themes in those responses included the expressed need for more tools and more opportunities to share and learn from each other on our work in health equity. If I can have the next slide, please. We're at questions.
If you have any questions, just a reminder just to type them in, and we'll come back to them very shortly at the end of the next part of this indicator.
Okay, I don't believe there are any right now, so I'll move on to the next slide. So this next indicator follows very closely in terms of content to the previous one, and is asking boards of health to describe if there have been any changes that have resulted from their use of the structures that were asked about in the previous question. So for example, if they have used a health equity assessment, have they, for example, moved where they provide a particular program or service to decrease barriers for priority populations? So this question has two dimensions. We ask them to describe any changes, or answer if there have been any changes, and then describe them so we can get a sense of the richness of experience across the province. If I can have the next slide, please. So why this is important. So the first one is really asking about processes and tools, but we also want to see if this is making a difference. This is from a learning point of view, getting examples of program changes helps us to illustrate whether use of health equity impact assessment is useful. And also we hope to uncover whether there's any patterns about where the use of these kinds of tools tends to start in a particular program or service area that might be helpful from a policy perspective in terms of encouraging others who are earlier on in their journey to have an idea of where people tend to start. If I can have the next slide, please. So, of course, there are some limitations because this is a survey that's asking people to report on their own activity. If it's filled out by one respondent, they may not actually know about all the kinds of planning done in various parts of the health unit, which might not be uniform across the organization. And also, health equity assessment may potentially occur without a structured tool and might be informal. So with that, I'll just pause for any questions.
Okay, none asked, so why don't we keep going then? If I can have the next slide, please. So the fifth indicator in our suite refers to strategic plans, and this relates directly to requirement 3.2 in the new organizational standards for boards of health. And I'll begin by telling the story of our own Board of Health here in Peterborough. Our 5-year strategic plan expired in 2012. So when the board sat down a few months ago to begin planning for its next strategic plan, the first thing they did was ask us to do an environmental scan and provide them with examples of boards of health that had done strategic planning that was compliant with the new requirement. So collecting this data and making it available in one place, we believe will be a valuable resource. This question asks about, well, the question is called, does the strategic plan describe how our health equity issues will be addressed? And we've broken it down into 4 components. So the first is just a simple the time period so that we can actually track as strategic plans expire. We should be able to see really a transformation of plans from prior to this requirement to plans that now comply with the new requirement. The second question asks for whether or not the achievement of health equity is promoted in your plan. The third question asks on how equity issues will be addressed. And then the fourth question is a question about targets, whether or not the Board of Health has actually included any targets related to health equity issues. Next slide, please. So as I said, we certainly believe that this indicator will provide us with valuable information. It could also be used to track the shift, as I was mentioned already, to including health equity planning, which is being encouraged by the new standards. However, we wonder whether or not what would happen in the case where boards of health are parts of regional governments. Sometimes regional governments will do strategic plans, and where public health is maybe just a department within regional government, it may be that there will be boards of health without specific strategic plans. So we certainly recognize that there may be some challenges for boards of health as we have a variety of governance models in the province for boards of health. Next slide, please. So I'm not seeing any questions. I'm going to move on to the last indicator, indicator number 6. And this indicator relates to the current provincial poverty reduction plan. Ontario is one of the provinces that has actually embarked down the road of making poverty reduction a priority. And this indicator should capture whether or not boards of health are engaged in local poverty reduction efforts that form a component of this provincial priority. And so the indicator asks just a simple yes or no question about whether the board is engaged, and it also asks for details about the types of activities and hopefully even the outcomes that have been accomplished locally. Next slide, please. We recognize that there may be situations where there are no locally organized poverty efforts, and so some boards of health may not be able to provide answers to this question, but it would actually be good to know that where this is the case, where there are no organized poverty networks active within communities. Certainly we haven't specified in our outcomes whether they are past outcomes, so some poverty reduction networks have been active since 2008 or 2009. We're interested right now at knowing whether there have been accomplishments and also future. So we don't specify past or future. It'll be interesting to hear whether or not we should do that to help respondents. And then finally, just the note that I've already alluded to, that we believe these responses could be very useful in creating a provincial inventory of public health activities that relate specifically to poverty reduction. And again, this could be very useful in knowledge exchange for other boards of health. So that brings me to an end of the 6 indicators, and at this point we are going to open up the question period to oral questions as well. So if you have an oral question that you'd like to ask either of the 3 speakers, just indicate by raising your hand. So if you, it's the 4th icon, if you press on that, your hand will be raised and we will be able to unmute your line so that you can ask your question directly. In addition, if you prefer to write your question, please use the chat box and I'll continue to monitor that for any written questions. So, are there any questions from participants? Hopefully the technology is working and I'm not jumping to a conclusion. That's incorrect. But I don't see any questions and I don't see any, I'm not hearing any oral questions. So I'm going to suggest that we move on to our last slide. Oh, sorry, I stand corrected. Monica Howe has her hand raised. Monica, are you able to ask your question? Let's see if the technology is working.
Thanks very much for holding this webinar, Rosanna, and to the other speakers for your work on this. I think it's great. I just wanted to clarify the first couple of indicators on the health status reports.
Sure.
I guess I'm a bit confused because I think you noted in your limitations that, you know, this percentage could depend on the number of reports generated and the way people choose to present the determinants of health and equity indicators. So for example, Peel has created a health status report solely on the determinants of health. And so you know, we also have additional reports focusing on other determinants specifically, and then also health outcomes like tobacco that then also look at social determinants. So I guess it just seems to me that there could be a lot of variation between health units. And I wonder if maybe perhaps looking at whether or not people address these indicators within their Board of Health reports rather than the number of reports themselves. Yeah.
That's a good question, Monica, and it allows us an opportunity to clarify. You'll see that the actual indicator is percentage. So, but you have to enter the number into the numerator and the denominator. So in your case, let's say for Peel, you know, you've done an omnibus sort of report on the health status, and maybe that's one report, and maybe you've done 2 others. So your total would be 3 in the numerator. Sorry, in the denominator, and then definitely you're going to have 1 for sure that addresses social determinants of health. It really will be up to you to determine whether or not you've addressed the social determinants of health in the other 2, and that's going to be used to derive a percentage. So if it's, you know, in some cases it may be 75%, it may be 100%, right? So, so you do need to use the numbers to in the formula for the derivation of the percentage. Does that answer your question?
I guess, like, I'm just wondering, I feel like every one of our reports addresses some aspect of social determinants. It's just, you know, how much weight is given or focus is given within that differs. And I just wonder if it would be, I guess, more important to say that every health status report produced addresses a social determinant of health.
Which would be wonderful. I don't think all boards of health are there yet, but certainly collecting this data and sharing it among boards of health could actually showcase boards of health who could be mentors for other boards of health that are just beginning on this journey. But please, if you have further questions or suggestions on that indicator, Monica, could you please include that on the survey?
Sure, definitely. Thank you.
Thank you. I see Selena has a question. What can we expect in terms of reporting on these indicators and to whom? Well, Selena, that's a good question. Right now, we are anticipating that these will be used as tools, and that it really will be up to boards of health staff to determine how they want to use them. I envision, for example, that the nurses working on social determinants of health might be interested in this. Epidemiologists might be interested in the first 2 indicators. There may be managers and planners who are interested in the priority population indicator. So there's a variety of interests. In addition, I mean, I think we're committed to see if we can actually create the inventory where and hold this information so that others can access it. But I think it still remains to be seen how these indicators are used, how useful they are, and that certainly will be part of the evaluation. Do any of the other speakers want to respond to Selena's question? Hearing silence, I'm going to assume the answer is no. And so let's move on to our last slide, and we can quickly wrap up and let you all get on to enjoying the rest of your lunch hour. So could I have the last slide, please? So just to recap then, we will, the e-survey, the link to the e-survey, and the actual document that describes the 6 health equity indicators will be posted on the Ontario Public Health Association website. And so you can find it there, as well as a copy of these slides. So they will be available. The actual request for the consultation has been sent to medical officers of health and CEOs. And that request was worded in such a way that we asked that the most appropriate staff be requested or made aware of the survey so that they could respond. So hopefully the emails are trickling their way down through the different organizational structures for boards of health, and will make their way down to the most appropriate people to respond. So that process has occurred. In addition, this past week, we did present the health equity indicators to the Performance Management Working Group and asked for their feedback. So that input has been received. Today's webinar it was another opportunity for questions both of clarification and hopefully for some feedback. We do have a few minutes left, so we can go back to the questions at the when I've completed this slide. We know that Cameron has taken the indicators to members of OPHEO, that's the Association of Epidemiologists who work in public health, and so we're very much looking forward to feedback from OPHEO. And what we're hoping to do is wrap up the consultation by the end of the month. We're going to leave it out for 4 weeks and then use the feedback to tweak the indicators. And we're aiming to potentially release a final version of these indicators by April, potentially at topic. We know there is a pre-topic workshop being organized by the National Collaborating Center on the Determinants of Health, and we've been given an opportunity during that day to potentially bring this work and release it. And once it's released, it will be available as a tool for anyone who wishes to use it. So, so that's the planned consultation process. And as we have a bit more time, I'm just going to go back to the questions to see if there are questions. And I see that Nazreen has a question about when the slides and recording will be available, as she missed that at the beginning. And I understand, I see here that Daniel has responded that it'll be a few days. So Nazreen, check back in by the end of the week. Hopefully that will be available then. So are there any further questions or any initial feedback that those of you who are still on the webinar would like to offer?
Rosanna,
okay.
This is Nakoshi. Hello?
I'm sorry?
Hi, this is Nakoshi. I just wanted to add some additional clarification.
Oh, please go ahead.
So I'm just looking at Doris Chartron's question about whether the survey is going to be sent to public health units to complete these indicators. There's actually 2 phases. So the survey that's going out right now is to get feedback on these proposed indicators based on the 3 questions about, is this actually feasible to complete? Do they seem appropriate? Do you have any recommendations for changes? So the first survey is just a consultation survey on, does this seem right? Then once we've taken that feedback and potentially made any revisions, then there will be a version that will come out later in the spring, hopefully for health units to complete. So we're not yet at the stage where we're asking for health units to actually provide data on the indicators. We're just asking for feedback on the proposed indicators at this stage.
Thanks, Nakoshi. And I see that there's also another question from Nazreen about how these indicators fit with Dr. King's recent indicators. So for those who aren't aware, last week Dr. King, the Chief Medical Officer of Health, released her 2011 annual report, and it was entitled Maintaining the Gains, Moving the Yardstick. And what the report is, for those who haven't seen it, it is a health status report, and the report does include indicators such as smoking and alcohol use during pregnancy, low birth weight, smoking prevalence, etc. So these are very specific health status outcome indicators, and certainly the social determinants of health do have an impact, and you will note that there has been both disaggregation and analysis provided as part of the report. So it's certainly a great template for boards of health who are interested in doing, as Peel has done, their own version of using local data that's available. But it really is very different from the 6 indicators that we're hoping or proposing that we use to monitor and measure exactly this kind of work, as well as other work that boards of health are doing. So related, but I'd say quite different. And I'm going to ask the other speakers if they would like to add anything.
Yes, I would say that, those proposed by Dr. King are really sort of the ultimate outcomes that we're trying to impact with our work in this area. And so they're indicators of health status, whereas these are indicators almost of the process of our work to ultimately have influence on those health status outcomes.
Yeah. Lynn Gates has a question. Will you provide a glossary of terms used in the survey? And actually, the answer for that, Lynn, is that there are definitions for the indicators, and the place to find them is within the indicator document. So I'm going to just encourage everyone to read the indicator document before you answer the survey. It is not an onerous document. It's let's see, how many pages is it? It's only 15 pages, and that includes the appendices. So there's a preamble. There are definitions and notes on every indicator. We've tried to highlight what the limitations might be, and I think you'll find all of the information very useful. So please do look that up in the actual document itself. Okay, I think seeing no more questions, I'm going to again thank all those who made this webinar possible, and thank you very much to the participants who took the time to come and participate in this. I hope you will now read the document and provide us with your input, your feedback. As I said, we're really looking forward to hearing from you and to working with you in this area, which we feel is very vital to our work in public health. So enjoy the rest of your day. Thank you very much on behalf of all the speakers.